We have our next speaker, who is Dr. Khusrav Bhajan, who is the HOD, Head of the Department of Emergency Medicine and Critical Care Consultant. So also has lots of credits to his account. He is the first person to bring AHA, BLS, and ACLS course to India in 2000. And so is also a recipient of Lifetime Achievement Award in Emergency Medicine. And he is also fellow of College of Critical Care Medicine. And so has co-authored two books, Textbook of Emergency Trauma Care and Signs and Symptoms in Clinical Practice. And he is a recipient and a featured India Today Top 10 Doctors of Mumbai consecutively from 2019 till 2023 as physician and in critical care medicine. We are really happy to have you, doctor. Over to
Thank
you.
you.
Your 20 minutes start now.
So I thank Dr. Sarvana and Dr. Srinath and the KAHO team for giving me this privilege to discuss about patient safety challenges, especially in the extreme age groups of pediatrics and geriatrics, especially in our ER. What happens is whenever we talk of patient safety, we think there is somebody standing over us with a stick ready to pound upon us and tell us what to do and what not to do. So I have really started, I'm going to start this talk in a way where we have some quotes and try to make it a little light and fun learning, but yet not compromising on the patient safety. So in the pediatric group, we have a very nice quote which says that every day I pray for the knowledge to care for the children and the resolve not to harm the parents. And for the adults or the elderly group, I would say that to care for those who once cared for us is one of the highest honors. There are some more quotes coming up. Safety is always first, and safety is not something that can happen on its own by accident. You need to work towards it with the right measures, the tools, and the mindset. And safety is the responsibility of every ER physician. Safety isn't expensive, it is priceless. Patient safety is a virtue that over time the ER team should possess, and there is no option but to practice patient safety in the ER. Some hard facts about the patient safety that now it is the core of modern healthcare. The concept of harm caused by the processes of healthcare is evolving, and injuries that was once thought to be unavoidable are now seen to be preventable and open to mitigations and even litigation. There is a growing evidence of the safety interventions that can be done to prevent harm in the patients in the ER. And therefore comes the doctrine, primum non nocere, do no harm. Here is a list of factors adversely affecting the safe outcome of patients in the ED, and these can be divided into patient-related, provider-related, and the environment or system-related. For example, in the patient-related, depends upon the type of emergent situation, the age extremes, which I will be talking about in a bit, communication barriers, language barriers, mental status of the patient, etc. In the providers, there could be burnout. You've been doing multiple shift duties before that, or you have had a bad day, rough day from the management or your boss. The experience in a certain field that you have not gained, like in pediatrics, etc. The environment could be inadequate staffing, inadequate equipment, no proper team member, overcrowding, and so on and so forth. So there are many issues which we need to actually address simultaneously. The three main hurdles as perceived by the healthcare providers in the ER are these three, and this is as per some data. That is the shortage of personnel during the busy hours, overcrowding due to boarding and long stay of patients in the ER, and then the lack of support from the hospital management in terms of infrastructure and manpower. And therefore, the national patient safety goals are divided into these 7. One is you must identify the patient correctly. Many a times you might, as already mentioned by our speaker, we may have the wrong identity of the patient, especially in trauma and disaster situations. Improve staff communication, and this can never be overemphasized. Use the medicines very safely. Look for all the allergies that the patient may have. Use alarm systems and do not switch off any alarm without knowing or troubleshooting why it was beeping. Prevent infection at all times with your hand washing and other barrier precautions. Keep the patient safe and keep yourself safe too. Identify patient safety risks And like in elderly groups and pediatric groups, we will come across all the points which make them the special situation or the population, and then prevent mistakes in surgery. But this probably does not apply to the ER unless we are shifting the patient directly to the OR. And the CAHO has also come up with a white paper called as the PREMS, and which has an 11-point or questionnaire, which actually addresses quite a few issues and takes the opinion of the patient. So coming to the special population in the ER, we have pregnant ladies, we have politicians, whom I consider a special population, trauma and burns, and then we have the two main, which I'm going to talk about, that is the child and the elderly. So as pediatric safety, let us discuss why it is so important. So again, some hard facts on the pediatric age group. For newborns and small children, it is not the kid, but it is the parents who decide if they need urgent medical assistance. These patients are still routinely treated in the ER, regardless of how severe or acute the primary problem is. The parents decide to bring them at 2 a.m. in the night because they returned from a party at 1 a.m. and they saw their child a little restless. So they will decide that the ER needs to be flooded with their kids. Earlier research also showed that up to 82% of pediatric visits in the emergency department were non-urgent, and therefore this led to inefficiencies, overcrowding, and negative impacts. So there is a lot of these pediatric patients which we will see. We might feel they are unnecessary, but it is our duty to make sure that they go home safe and sound along with happy parents. When we talk of pediatrics, earlier days, I used to say that, oh, the weight of the kid is 10 kg, so it will be 1/5 the adult dose. But remember that a child is not a smaller adult and an infant is definitely not a smaller child, and one size does not fit all. When we talk about pediatric patients in the ER, we have a little different approach, and that would be looking at the appearance of the child, the work of breathing of the child, and the circulation of the skin, whether there is pallor, cyanosis, etc. And we would do assessment, we would recognize the problems, and we would do care, which goes hand in hand in a horizontal approach. Treat the parents along with the child is my dictum, because it is always to reach the child, you need to first listen to the parents, gain their confidence, and only then will they allow you to touch their children. So pediatric triage in the ER has different signs and symptoms, and for time constraints, I won't be able to go through all. But in the emergency signs, which are very, very pivotal and you need to act immediately, obviously hypothermia, apnea, which is about the same for everybody. But severe respiratory distress, the rate is 70 here, whereas in the priority signs, if you see, the respiratory distress rate would be more than respiratory rate of 60. Even the heart rate would change in children from adults, and that would make it extremely important for us to have a different pediatric triage in the ER. So the common complaints that the patient would come in the emergency department, a child would come in, would be a respiratory problem like asthma, croup, or foreign body obstruction, anaphylactic reactions, dehydration very commonly, trauma and falls, abuse, epilepsy, again very common, infections which could be meningoencephalitis or some tropical illnesses, and unnatural like drowning, poisonings, and burns, because this extreme group age can definitely cause these problems to bring them to the ER. And parents want immediate attention, even if it is none of these above, and it may be just a mild low-grade fever, or the kid is not behaving the same way as it was a few days earlier. This is again a very nice chart where majority of the symptoms or the conditions which I mentioned above are responsible for the ER visits. But this is an even more interesting chart. Why are kids brought to the ER? My baby's problem is very important. My baby's doctor is not available. I think my baby will be seen much more clearly and quickly in the ER. And someone told me else that we took our child to the ER and they give very good attention, etc. So there are various reasons where you need to pay adequate attention to the parents as well. Now, why is a child age group or a pediatric age group so special? we understand that they have large tongues, they have larger floppy epiglottis, they have narrow points at the cricoid cartilage, and so on and so forth for the airway, which makes intubating, the position of the intubation different using the straight blade intubation laryngoscope, also a must here. As regards the head and the cervical spine, we know that the occiput is big, and that again comes in the way of intubation. There are some cardiovascular and other changes, but what is important to note here is that up to 30 to 40% of circulatory blood volume or volume loss can have almost no physiological change in the patient's heart rate, respiratory rate, or blood pressure, as they can compensate easily. But after that, they would absolutely deteriorate rapidly. So therefore, we need to understand these physiological and anatomical differences in a child before we embark on our treatment for the pediatric age group. And that brings me to the 10 important performance key markers in the pediatric emergency care. And that would be patient triage, infrastructure, patient-centered. And I'm not going to read all these, but this is important that we measure the weight in kgs, at least in India, identify the age-based pediatric vitals, and we have the Broslow tape for that, the door-to-provider time, the length of stay, pain management, and how we counsel the parents. I have just made this mnemonic of ABCD and added the squares to that, A2, B2, C4, and D4. And this is just my wavelength where I have tried to put this in for us to not miss things. And that is A stands for airway and also assess for abuse. B would stand for breathing and bleeding. C would stand for circulation, coma, convulsions, and counseling the parents. And D would stand for diagnosis, the doses, because they are so different, the disposition. You need to be confident when you are looking after a child, or for that matter, any patient that comes to the ER. Don't be overconfident, but don't be nervous. Otherwise, they don't get the respect and the confidence in you. And then comes the next D, which is dehydration. I think if this is a very important slide in which if we look at all these, we can keep the patient safe. And whenever you are in doubt, it's absolutely all right to look at your savior, which is the Broslow tape. And this gives you the blue, orange, and green, depending upon the weight and the age of the patient. You must put these up in your ER somewhere where they are visible. And these are the formulae for your endotracheal tubes, your defibrillations, your systolic blood pressure, the normal physiology of a child as per the age and the weight. And you can also keep your wet flag chart ready where you're talking about the weight, the energies of 4 joules per kg, the tube size, etc., and the lorazepam, adrenaline, and the glucose injections and the doses. So I would sum up here for the pediatric section. Sorry, I think have 10 more minutes to complete the geriatric one. In the 5 big that the pediatric ED safety would account for is the parents. And I'm harping on this many times because they can be a hindrance in the actual care of the child. Second would be the doses, which you need to memorize, or even if you can't, then you need to have your Broslow tapes and be very particular about these. You must always look for dehydration and the causes. And remember, the physiology of the child does not manifest itself as a volume loss until 30 to 40% is lost. And then the convulsions, febrile convulsions or otherwise, and the trauma that might be coming in with kids, especially you can have scivora in spinal injury. You can have a lung contusion without any rib fractures or flail chest because they have much more mobile ribs. So all these differences need to be kept in mind. Coming to the geriatric patient, and this age group is very common, and almost 20% of our ER visits are done by them. And this is a very stupid cartoon here. The good news is that there is life after death, and I don't think we should be ever talking about this. Also remember, we keep saying one size does not fit all, and we have Sylvester Stallone here, who's 78 and fit, and somebody who's probably a smoker and has very, very increased frailty index. There is a definition to old. Now, we never like being called old, and I think we are heading towards that, at least I am. 60 to 70 is old, 70 to 80 is older, and 80 plus is oldest old. So there is a definition here as well, because the entire immunity pattern and many other things can be changed. And this is an old definition. You may call yourself young old or middle old or old or oldest old. So the elderly account for 65% of ED patients with sepsis. So if there are 100 patients, 65 of them would be elderly population with sepsis. 3 times more mortality with pneumonia, 10 times more mortality with UTI, and 25 times more mortality with meningitis. And they are a unique population. So why is the elderly population so different? Yes, they are unique because many a times they can have a bad infection, maybe a pneumonia, maybe a urinary tract infection, and still not manifest with fever, leukocytosis. They may only be complaining of lack of appetite and a little lethargy or drowsiness. So you need to pick up these patients, the infection in these patients, and many other things which we will discuss in the next few minutes. They are a high-risk population because they have lots and lots of comorbidities, may it be hypertension, cardiac failure, renal failure, which affects your dosing, which affects your monitoring of these patients. And beyond the age of 70, they have 5 comorbidities, and this is a given in most patients. This leads to decreased immunity, malnutrition, decreased mobility, social factors, polypharmacy, and mental agility being affected. This is another very nice study, though old, where it says that there are 3 or more chronic illnesses in adults, which are 50% or more in the men and the women put together. So why is the elderly population different here? We know that there is an increased risk of delirium in these patients, lack of visual and hearing problems, respiratory system, they would have decreased vital capacities, and they would be more prone to infections. Cardiovascular, they may have had a cardiac event earlier, or they may have just a reduced exercise tolerance, increased postural hypotension, wider pulse pressure, and so on and so forth. And usually their GFR is also compromised because of all the NSAIDs and many other things that have been taken for the last 60, 70 years. So this makes an elderly population extremely special in our situation.
So your last 5 minutes, please.
Yeah, 2 or 3 minutes. This makes them increasingly prone to pressure sores, risk of infections, delirium, and then frailty definition, which is very important, known as the dependency, the vulnerability, and the comorbidities put together. And we have a nice diagram or a chart which tells them very fit till terminally ill. And also, to add on, they have osteopenia and sarcopenia. So if there is a trauma patient, they would have, again, many changes which we have mentioned, and always be aware of them being abused, and early recognition would help for future trauma in these patients. And because of all this, we also need to think of their quality of life, their end of life, and the palliative care. And if you do so, then you have to think of the death protocol, which is discussion and decision, ethical issues, appropriate care, team effort, and holistic approach. Coming to the triage, as I mentioned, they have delayed presentations. They do not take pain very easily, etc. And therefore, you have a different assessment, global comprehensive scoring system, and that can be looked at. But these 5 M's are very important. That is the mind, the mobility, the medications, which is the polypharmacy, the multi-complexity, and the matters which are important to that patient, like end-of-life care, etc. And you can have a chart like this ready so that you don't make any mistakes, and this can help you monitor the patient safety in the geriatrics. And there are lots of problems like resource constraints, inefficient technology, clinicians, and so on. So CAHO has again written a white paper on this recently, and they've given a 17-page questionnaire, which actually tells us whether these patients are going to be safe or not. So my 5 important points, or the big 5 in geriatric ED care to keep them safe, would be infections and looking for them, the trauma patient in these patients, delirium, frailty index, and the abuse that might happen. there is a new concept or a model which is not only input and output, but also the throughput, which is the process. And here, as you can see, there is special needs during the throughput where you are looking at the pediatric and the geriatric age group. When nothing works, AI in healthcare is definitely useful, and it not only improves quality and efficiency, but reduces the risk of errors, streamlines patient experience, improves continuum of care, and aids in precision medicine. This is my second last slide, where the 6 domains are very important. That is, you must develop a culture for your patient safety. You must believe in team spirit, communicate effectively, manage the risks, optimize human environmental factors, and recognize and respond and disclose your adverse events rather than stopping them. There can be 5 R's and 5 C's: right patient, right staff, right medication, right dose, right counseling. And we all know that competency, care, communication, commitment, and compassion can actually help us prevent any damage to a patient who's already sick. So in summary, a child will always have parents dictating terms. Their emotional quotient needs to be matched by our knowledge and compassion. And the patient is crying, and it's a chaotic atmosphere in an already chaotic ER. Elderlies would have comorbidities, frailty, dementia, polypharmacy, and palliative. And I end here by this quote. And whenever we are challenged, we should rise above ourselves. And as caregivers, we should be caring, always there, ready to give their all, encouraging, gracious, incredible, valuable, exceptional, and respectable. Sorry for exceeding the time. Thank you.
Thank you so much, doctor. It was really, really wonderful. I'm sure it was very difficult for you to manage your time having two set of people, elderly and in pediatrics, but really a wonderful session. Thank you so much for your